second, so we'll just take a minute and have a recess until she gets here. And somebody just told me she's walking in, so there she is. All right. Yes, it's still 8:30. Okay, Jenna, if you could take a breath, and then she'll give us a bill brief. Mama of a sick little child, so we're going to forgive her for being just a little bit late. Yes, no problem. Deep breath.
Good morning. Thank you, Madam Chair. This is Senate Bill 103, and it relates to the practice of dentistry. The first change, it's all amendatory. It's in Section 1 in Men's KSA 65-1430, and this adds a requirement as a new subsection B to provide information to patients. A treating dentist would provide basic information about the dentist and the practice ownership. And this would include things like the full name and after-hours emergency contact information and the license number of the dentist and the practice owner. Subsection 2 amends KSA 65-1435, and this would strike the requirement in subsection D. Current law would require a dentist spend 20% of the time personally in the office if a dentist wants to have their name on the dental office or clinic, and this would eliminate this requirement of personal presence in any practice, that 20% requirement. Subsection 3 amends KSA 1436, and this would add as an act that would subject a licensee to discipline. The act would be to direct or pressure another dentist who is an employee or subordinate to perform dentistry that fails to adhere to the standards of care. And the last change is in Section 4. This amends KSA 65-1467, and this would prohibit a dentist or a dental practice to require a patient to sign an agreement that would limit or prohibit a patient's ability to file a complaint with the dental board. So if an issue came up, there could be no contract that would require a patient not to complain to the dental board. And I'll be happy to answer any questions.
Any questions for Jenna? Oh, I'm sorry. Yes, Senator Petty.
Thank you, Madam Chair. So, Jenna, on page 2, the section starting on line 17. So, with that removal, then a dentist that might have multiple locations, there is no requirement for a presence there at all.
Correct. With the striking of this language, a dentist could have several practices with their name on them and would not be required to personally be present at that office for a specific amount of time.
Thank you.
Committee, any other questions? Thank you, Jenna. We will begin with proponent testimony, and we will start with Mike O'Neill.
Thank you, Madam Chair and members of the committee, and congratulations on your graduation to a new mode of ambulation.
Oh, that's quite a mouthful. Thank you, Mike.
Yeah, thank you for the opportunity to be here. My client is the Association of Dental Support Organizations, and so their membership are made up of dental support organizations. And essentially, these are business management organizations, and in the interest of time, I'm going to let one of our members, Heath Hall with Heartland Dental, kind of explain a little bit more about that model. This is not a DSO bill, but it's we sponsored the bill on behalf of dentists that not only have a DSO model, but all dentists who are licensed in the state of Kansas. The bill is also a collaborative effort with the Kansas Dental Association, and so I'm going to pretty much talk about the aspect of the bill that we are interested in. Kevin Robertson is here with the Kansas Dental Association to talk about some additional language that they requested, and we agreed to add to the bill to make it work for everybody. Under current law, and the law has been on the books since 1943. It's a little archaic, but there was a law in Kansas that was pretty much unique to Kansas that required any dentist that had an ownership interest in an office to spend at least 50% of their clinical time in that office. That really didn't help with quality of or access to dental care. And as you know, we have many dental care deserts in the state. There are actually 24 counties right now that meet the definition of dentally underserved, and they're not all in western Kansas. There are actually 8 or 9 of those counties that are in the eastern part of the state, including 3 that surround Shawnee County. Now, that law was changed in 2014. There was an effort to eliminate that rule, and in that year, they compromised and took it down to 20%. The Kansas Dental Association will be the first to admit that in the 9 years, 8 to 9 years since, that still has done nothing to increase the access to dental care in the state. There are 2, on page 2, there are 2 subsections that we strike. One is actually the 20% rule, but then the next one is in subsection F that actually created an exception to the 20% rule in those areas of the state that were dentally underserved. And there, a dentist could open offices, multiple offices, if they were within a 125-mile radius. Again, probably a nice thought, thinking that that would maybe incentivize more dental offices. It did not. And so there really isn't any reason to keep the 20% rule. And instead of promoting access to dental care and improving the quality of care and getting specialty dental care out there, it has really served as a barrier to that. So I want to very quickly contrast that rule that applies to dentists. So 2 things. Kansas is the only state that has this. And number 2, may be the only profession that has it. So contrast this with the rule for optometrists in Chapter 65, Section 1522. They proactively state for optometrists, a licensee shall not be limited in the number of locations from which the licensee may engage in the practice of optometry, period. In dentistry, just maybe to anticipate a question, it's not that there's not a dentist there. Every office in every dental office in the state must have a licensed dentist. They have a license, they have a name, they have patients, but you may have individuals who choose to own multiple offices and have a professional association practice and associate themselves with other dentists. There really isn't any reason anymore for that dentist to have to spend 20% of their clinical time in any of those offices. So anyway, that's what we're talking about. In terms of the DSO model, other states have many dentist offices that support the DSO model. We don't have that many in Kansas. As a result of eliminating this rule, there would be an expansion of that type of office, as well as hopefully other offices providing dental care. We did, during the interim, take the opportunity to have some site visits. We did a couple in the Wichita area. We did one up in the Johnson County area, and one recently here in the Topeka area. Senator O'Shea was one of our guests for an office visit here, where we could kind of introduce them to what a DSO model does. It basically provides all of the non-clinical aspects of the practice to allow dentists to do what the dentists really thought they were going to do when they got out of dental school, and that is practice dentistry. And they got to hear firsthand from the doctors who talked about their appreciation for the DSO model, and more importantly, what it might mean to get rid of the 20% rule so that they are not inhibited in their ability to expand. We appreciate the fact that we also took this measure to the Kansas Dental Board. Lane Hemsley is here. He was very gracious in getting us on their agenda so that we could brief the dental board about this. Obviously, this is a policy decision, and the dental board is not going to take a position on policy. They will obviously enforce any law that is passed, but voice no objection to us proceeding. We also want to express our appreciation to Kevin Robertson with the Kansas Dental Association. He's got a diverse group, obviously, and there may be those who would prefer to keep the rule in place. I suspect that may be for anti-competitive reasons. I don't know of a legitimate clinical related or patient care or access to care type of reason why there would be objection, but there may be some objection, but we appreciate their board taking the position that this is one that they could work with us on. They, as I mentioned, will have they have some language in here. They vetted that with us. We were totally on board with it, and so we appreciate very much if the committee would favorably respond to this bill. I do want to point out that there is written testimony from Dr. Dan Thomas. Dr. Dan Thomas is a dentist in the Johnson County area. He does not have a DSO. He does not contract with a DSO, individual dentist. You read his testimony. He unfortunately can't be here today because he's got patients, but he actually had a very bad experience with this rule. He's not only an individual dentist, he's a former member of the Kansas Dental Board, but more importantly, he was an individual that found himself crossways with the rule at the time. He wanted to provide additional care in Manhattan, was unable to do that. Actually got involved in a office here in Topeka. There was a complaint filed. He ended up divesting of the ownership there. So has that stopped Dr. Thomas from expanding? No, he just had to expand offices in Missouri because Missouri doesn't have that limitation. And he wants to be present in Kansas, as do a number of other dentists. About 30% of the graduates now do the DSO model. Why? Well, because they're coming out of dental school with a huge amount of debt. And they just can't afford to buy all the new fancy equipment and buy offices and all that stuff and have professional management. DSOs allow them to have that professional management and get them set up in their early practices and have state-of-the-art equipment. And Heath Hall will tell you a little bit more about that. Be happy to stand for questions at the appropriate time.
Thank you very much, and I appreciate the conferees keeping their statement. No, you did fine, Mike, keeping their statement short, not getting on to you. So if we could take about 3 to 4 minutes at maximum for each of our other conferees, and let's now go to Health Hall, who's Vice President of Government Affairs.
Thank you, Madam Chair, Ranking Member, Committee. My name is Heath Hall.
I'm
I
sorry.
wish it could be health. 'Cause I'm here. I'm very interested in health, oral health. But thank you so much for holding this hearing and considering this bill. I work with Heartland Dental. We are a national DSO with a presence in 38 states. We have over 1,700 offices, and we support over 2,700 dentists. Unfortunately, in Kansas, currently, we only have 3 offices that support 5 dentists, and we would love to make that number larger and help get more access to oral care throughout the state in the rural, suburban, and urban areas. As Mike said, Kansas is a state that has a lot of oral and dental deserts, and they're not all in western Kansas. Urban areas also often lack the necessary dental care. We kind of come to a number that you need 1 dentist for every 3,000 individuals living in a community. So if you take your own communities and kind of think about the size they are and roughly how many dental offices you see, you'll probably come to the conclusion that you could use more dental offices to support that community. What is a DSO? Essentially, we are a business entity that allows dentists to be dentists instead of small business owners. Their focus can be on the patient, on increasing their skills and knowledge, learning new technology. As AI becomes a bigger part of dentistry, that's going to be a big learning curve. Instead of having to do the daily tasks of a small business owner, from managing their team through the HR, through accounting, through fixing a pothole in their parking lot, or in Florida with the recent hurricane as an example, we had a number of offices that were damaged there. So if there's a natural disaster, they know that there's going to be a team of people there immediately to help them to reduce the amount of time their offices are down and to be able to get back to the practice of dentistry. This model is particularly attractive to younger dentists that are coming out of dental school with $300,000, $400,000, $500,000 in debt. The average dental office, depending on geography and how much real estate costs, can be anywhere between $1 and $2.5 million to start. So many of these young dentists could be looking at $2 to $3 million in debt before they even see their first patient. A lot of them are choosing, as Mike said, about 30%, and that number grows every year, to go the DSO route. They don't have to go into that extra debt. They can join a professional corporation which hires the DSO. And in this instance of what we're talking about with the 20% rule, a doctor that owns the professional corporation could hire them and place them in one of their offices. And you'd have a fully licensed practicing dentist in that office that could provide oral care to that community. DSOs also provide state-of-the-art technologies that often are not found in all dental offices because of cost. Our ability to buy in scale allows us to get new technologies at a more affordable price. So we hire great dentists, and we provide them with really good technology and continuing education. I think that what will this do for Kansas? Heartland Dental, we're prepared to come and invest in the state and grow. Like I said, as an example, Iowa, we have 11 offices, 15 doctors, and we saw 2,400 patients last year. In Kansas, we have 3 offices, 5 doctors, and we saw 7,800 patients. I'd love to be able to get more towards Iowa and Kansas, and even perhaps larger than that, so that we can help provide care to Kansans. Although I work for a national organization, I do live in Overland Park, and I am a Kansan, and I would love to see that here. So I'm happy to answer any questions that you guys have. Try to keep this short, but this is important for the oral health of Kansas. And one thing I will note on oral health is that it's not just about your teeth, it's a full body health. Our dentists often discover oral cancer, diabetes, high blood pressure, other things. So if we don't have the access to oral care in the state that we need, folks might not only be having tooth issues, but they may not have other things discovered. So help us help the state and reduce those dental deserts, provide more oral care. And I would greatly appreciate a favorable consideration of Senate Bill 103. And again, I thank you for your time, and happy to answer any questions when the time is appropriate. Thank you.
Thank you, Heath. And in defense of Danola, when you are the assistant for the Health Committee, any word that looks like health becomes the word health. So, now I'd like to welcome Kevin Robertson, with the Executive Director of the Kansas Dental Association.
Good morning, Madam Chairman and members of the committee. I am Kevin Robertson, Executive Director of the Kansas Dental Association, and I'm here to give my thoughts, or the Dental Association's thoughts, on Senate Bill 103. So, as we've already heard from Jenna, we kind of know what the parameters of the bill are. We know it removes the 20% rule. We've talked about the 20% rule and what that means. I will tell you that when the Association of Dental Support Organizations came to us, we were quite concerned about that. I will tell you that the Kansas Dental Association and its members have leaned on the 20% rule as a way to create and ensure accountability between their patients and that dentist who might own a practice. So, if a dentist owns a practice all over the state, how do we know that they're overseeing those practices and those employee dentists in those other areas of the state? So we did have some concerns. I will tell you that removing the 20% rule is quite controversial for the membership of the Kansas Dental Association, and perhaps you have received some emails or phone calls on either side of that, or perhaps you will over the next few days. I do appreciate Mike O'Neill with ADSO coming to the KDA. late summer, early fall, I don't recall the exact date, but, and talking to us about the thoughts regarding removal of the 20% rule. Though we were initially very much opposed to that, we did step back. Our leadership took a look at that and thought, well, are there ways we can replace the 20% rule with other provisions that would ensure transparency, accountability, and patient protection? So we sat down, we looked at those things over the last, I don't know, maybe it was November, December, I guess. We probably did that. And we presented those to ADSO, and they did graciously accept those. So those four provisions that we talked about, again, Jenna mentioned those. The transparency provision, if you will, is on page 1, 19 through 25. So we think it's important for a patient when they go into a dental practice to know who that owner is in that dental practice, if they're going into a satellite or whatever type of a practice it is, because if they have a clinical issue that might need to be addressed, we want them to have the ability to go back to that owner, express that concern, and then also have emergency contact information and other information that provides them with the ability to complain, but also get treatment decisions and talk about their treatment plan and what might or might not be done. So secondly, accountability. We have added a 21st discipline on the list of disciplines within the Dental Practice Act, and we've created a discipline that holds that dentist owner responsible for the actions of those employee dentists under their employ. So whether you're a supervising dentist and you have a subordinate dentist, maybe in a clinical setting, an FQHC or something, or you are a dentist owner and you have an associate or employee dentist, and that employee dentist maybe does something that falls under some level of scrutiny, it has a complaint filed, that a dentist owner can also be held responsible for that under the Dental Practice Act with the dental board. That provision is on page 4, lines 36 through 38. Then lastly is a patient protection provision or another patient protection provision. We talked about this a little bit last year in committee for those of you that were here on a different bill, but we are aware of at least one entity that does require their patients to sign an agreement that limits that patient's ability to file a complaint with the Kansas Dental Board. Now, whether or not that would hold up with the Attorney General or in court, we don't know, but we want to make sure it's clear that no dentist has the ability or can have a patient sign away their ability to file a complaint with the Dental Board. So that's the last provision that's in that. We are looking at, lots of things. Obviously, we heard testimony from Heartland Dental and Association of Dental Service Organizations. I will tell you again, there are members that are concerned about some of the things that, that were probably would have been said here. There are areas of our state that do have, definitely need more dentists. Where are those dental practices going to locate? If they're all going to locate in Johnson County, that's not helping anybody else. So we want to create opportunities for our members to be able to expand, for private practice dentists as well without some of the restrictions. But there are concerns that, dentists have about kind of where and how they might expand and how that might happen. There is a concern, again, about then what that accountability is of those patients as those practices expand. So as you hear from dentists on both sides of this issue, you'll probably be hearing some of those thoughts as well. So with that, I would stand for any questions. At the end of the day, we support the bill with the provisions that the KDA has in it as far as removal of kind of the 20% rule. I would say neutral or probably opposed to that, but again, appreciate the opportunity to kind of work out some of these other things with ADSO.
Committee, I had originally placed on the agenda that we would have final action on this bill tomorrow. However, after visiting with I was contacted as well from some of the general dentists, and after visiting with you, Kevin, this morning, giving you an opportunity to talk to your members, some of them that are concerned, we will move final action till next week.
I appreciate that, Madam Chair. Perhaps there's a way that we can work with ADSO to find another provision or a piece that would kind of work to make the bill even better than it is now.
Very good. Committee, we have just a couple of minutes for questions. So for any of the proponents, Dr. Steffen.
Thank you. To the Heartland Dental gentleman.
Yes, sir.
Appreciate it. Hey, help me understand how the relationship works, your corporate structure, the relationship with the dentist. Are they employees, et cetera, et cetera?
Sure. So licensed dentists form a professional corporation, like in, lawyers, accountants, many of them have. And there could be one dentist or multiple dentists that form that professional corporation, and then they hire the dentists that would work for them. So let's say that a professional corporation had 20 offices in it, and let's say there are 2 dentists that own the professional corporation. They would hire at least 18 dentists. Many dental offices have 2 or 3 dentists working in them, so it could be 40 dentists if they were going to be larger offices. And they would be employees of the professional corporation. They are not employees of Heartland Dental. Heartland Dental staffs their team for them. So the dental assistants, the hygienists, the front office workers, any of the administrative folks.
Okay, can I follow up, please? Okay, so basically it would be Heartland owns the bricks and mortars and staffs it. So it'd be like a hospital, basically. And then you have the independently practicing physicians as a group interfacing with the facility. Do you all send your own bill to the patients, or how are the patients billed in that circumstance?
So that's going to vary by office. Each doctor runs their office and chooses, which providers they take insurance from, or if they're fee-for-service or Medicaid or Medicare Advantage. So it's going to vary by doctor and what they are comfortable with. Some doctors only want to do fee-for-service. Some doctors...
How do you guys make money?
We make money through a fee arrangement with the professional corporation that is...
Meaning, what's a fee arrangement?
Fee arrangement would mean, okay, you want, let's say there's a menu of services. You would like us to come in and do your accounting, your HR, your legal, whatever you choose off of this menu of services. And those services come up with some type of a fee arrangement depending on what you've chosen. And, there's a contract entered.
One more follow-up.
Yeah.
Does Heartland own the bricks and mortar?
We own some, we rent some, and some are owned by the doctors. It just varies by location.
Thank you.
Thank you.
Senator Blasey.
These questions are for Kevin, if you don't mind coming up, Kevin. When a patient goes in for a routine cleaning, are they required by law or rule to see the patient every time they go in for that 6-month cleaning?
No, there is, in the General Practice Act, there's a provision for hygienists that allow a hygienist to work under what we call general supervision. So if somebody was going to go in for a cleaning, a dentist would not have to see the person for an exam. They can't be, the patient cannot be billed for that exam, though. I mean, you cannot, an insurance company won't pay, and you can't bill for an exam for that patient. So usually if you went to a dentist and it was a hygiene visit, let's say, you would have your hygiene visit, your prophy, maybe get x-rays, and then you would also have an exam by the dentist. All those are separate billable items, procedural codes. If the dentist isn't there, you can't be billed for the exam.
Okay. You mentioned there might be some opposition from the membership, from the dentists, and I appreciated having dental day last week in the Capitol, talking to a lot of the dentists back home. But it seems like overnight, my email has exploded with opposition, particularly from my district. I've heard from 5 dentists, and then my own personal dentist called me this morning. And so I'm hearing a lot of opposition from back home. And we don't have a shortage of dentistry in my district, so you can drive around, feel like there's one on every street. But I'm hearing from them all, and they're also going to be very concerned about the quality of care. So my question is, how would you respond to these dentists who are concerned about the quality of care if the 20% rule is removed? What would your responses? I'm just trying to understand better everyone's perspective.
I appreciate the question. I think there's good and bad actors probably in every profession. And there are concerns that some of those bad actors might expand and provide more dental care. Whether or not I don't want to single out any individual or group or organization. Again, good and bad actors in any profession. So I'm going to walk that tightrope on that particular question, Senator Blasey, but I do appreciate the question.
Senator Petty with the last question.
Thank you, and one is for you, Kevin. So you are listed as a proponent, and you did say that with those 3 bullets that are 3 things that have been added to the bill, but then you were
Wishy-washy.
wishy-washy at the end. So what I'm asking, so did your board take a position in support of removing the 20%?
Took a position not to remove the 20% rule per se, but with the provisions that I laid out. That is correct.
So they took a position not to remove the 20%, but having the provisions that you mentioned in place.
That is correct, and I will tell you that we are reviewing that decision.
Thank you. And my other question is for Heath. Heath, you made, from Heartland, thank you, and it is Heath, is that correct?
That's correct, yes, thank you.
But you are into health, so I guess.
Yeah.
So
I'll answer by either.
you made a comment in your last response. You said that each doctor runs their office. So then I'm a little confused, then perplexed. Then each doctor runs their office. Then what's the problem with the 20% rule?
Well, each doctor makes the decisions in their office, so we don't decide if they're going to do a treatment X, Y, or Z on a patient. We don't decide if they're going to use Colgate or Crest, or whatever the particular product that they may be looking at. The problem with the 20% rule is that it does not allow these doctors to grow their businesses. There is under no other state in the country does not allow a doctor to own, I guess technically you could have 5 offices in Kansas if you spent 20% of Monday through Friday at each office. In any other state in this country, a doctor could own 5 offices or 500 offices. So the problem is, it is a regulation really without any sort of clinical backing. There's nothing that impacts patient care. To answer kind of the patient care question, I would say that our doctors have access to world-class continuing education that many solo dentists do not have. We have, as I mentioned in my testimony, access to the most cutting-edge technology and the most cutting-edge advancements in dentistry due to our ability to purchase at scale. We have incredible mentoring opportunities, and many solo doctors end up in the DSO towards the end of their career because they're looking to slow down and have a different quality of life, maybe not work, a 40-hour, 50-hour week, but maybe work 2 or 3 days. And so those types of doctors with all this experience, if we were not allowed to open up additional offices after they've maybe sold their practice, would really have nowhere to go. So that's another issue of losing this talent that exists by essentially not letting a non-owner doctor have an opportunity to go into one of these practices that a PC would own. Does that answer your question?
That was a lot of information, more than what I was asking for. I'm still not sure you really spoke to the 20%, but I'll stop there. And
We have another presentation, but I have 2 senators that promised me they have very quick questions for you.
Mine's a quick comment. I was able, thank you, Madam Chair. I was able to tour Aspen Dental here in Topeka, and to me, it's a model that allows for, I got to ask lots of questions and meet the owner and the head dentist. He wants to expand. Some dentists are interested in the business side, some aren't, and I think that this model gives them the opportunity. He wants to expand, but his time's already, strapped by that 20% rule. So I guess I would just encourage those who do have questions, maybe that they could tour the one that's right here in Topeka on Wanamaker. Thank you.
Senator Blasey.
Thank you, Madam Chair, for my quick question. Following up on Senator Petty's, your response, Senator Petty, it kind of sparked another question in my head about quality of care. So if you hypothetically can have 5 practices or brick and mortar businesses in the state of Kansas, and you can spend 20% on each one, wouldn't that potentially decrease the quality of care for your patients? And if we have deserts across the state, whether in inner city or rural, and you're trying to build your practice, and if there's truly a desert, I mean, can't you grow a practice in a desert? I mean, there's so much need. And so I guess my question again to you would be quality of care.
Yeah.
Based on the 20% rule.
No, I think what you just said is exactly right. With having a 20% rule and requiring a dentist to go from office to office 1 day a week certainly could diminish the quality of care. If we eliminate the 20% rule and allow that doctor to spend their full time in their primary office and then hire other qualified and licensed dentists in the state to support the other offices they have and spend their full time there, that would certainly increase the quality of care. So I think your point is exactly a good one, that by the law requiring a dentist to spread themselves and maybe have to drive an hour or hour and a half, each day to a different office, that certainly could diminish the quality of care.
Thank you so much for all of our conferees today, and this concludes the hearing on SB 103. And committee, I would move your attention now to a presentation from the Senior Care Task Force, and this is Leanne Thone.
Good morning, Madam Chair, members of the committee. My name is Leanne Thone. I'm a research analyst with KLRD, and I am here to present to you the Senior Care Task Force final report. And this should be included in your testimony for today. The Senior Care Task Force was established by 2021 House Bill 2114, and it was made up of legislative and non-legislative members. So there were industry professionals and stakeholders who participated in this task force. The House bill directed study for this task force on a few topics, including the provision of care for Kansas seniors who suffer from Alzheimer's, dementia, and other age-related mental health conditions, administration of antipsychotic medication to adult care home residents, safeguards to prevent abuse, neglect, and exploitation of seniors, adult care home surveys and fines, funding and implementation of the Kansas Senior Care Act, senior daycare resources in the state, and rebalancing of home and community-based services. So the Senior Care Task Force initially met 4 times in 2021, and then they sought and received approval from the LCC to create working groups. And this was coordinated by KDADS with the Kansas Health Institute, who facilitated those working groups. And the working groups were directed to pursue study of topics that were discussed and recommended during those first 4 meetings in 2021. So based on those recommendations and discussions, there were 2 working groups and 1 subgroup that were created. The working group on quality of care and protective services, the working group on access to services, and the subgroup on workforce, which was formed to study the workforce issue and make cross-cutting recommendations, since that is an issue we know covers almost every area right now of healthcare. The working groups, like the task force, were made up of industry professionals, stakeholders, and legislators, and they met virtually beginning in December 2021 until July of 2022, and were facilitated by staff from Kansas Health Institute with support from KLRD. The working group's report is an attachment to the final Senior Care Task Force report, so you will see that as the second item in that packet that you got. It's a little thick. The working groups developed recommendations, and for each one, they provided a rationale, scores for ease of implementation and potential for impact, and considered which agencies and organizations could lead the action for that recommendation and collaborate on implementation. Each recommendation also provides key performance indicators that can help evaluate each recommendation if they are implemented. The working group's report was finalized and presented to the Senior Care Task Force in August of 2022. And then the task force discussed the recommendations in that report and made modifications to some of them. And those changes made by the task force themselves are reflected in red in that attached report. And one of the nice things about the report is that it presents those recommendations in a few ways. So you will see those recommendations by tier or by priority, starting on page 19. You will see the full descriptions of each recommendation by category, beginning on page 30. And this is where you'll see the full recommendation with those rationale and scores for ease of implementation and things like that. The categories include cross-cutting, which were the working group, the subgroup on workforce recommendations that don't really fit in one category, administration of antipsychotics, safeguards to prevent abuse, neglect, and exploitation, adult care home surveys and fines, care for Alzheimer's, dementia, or age-related mental health conditions, rebalancing of home and community-based services, senior daycare resources in Kansas, funding and implementation of the Senior Care Act, and workforce. So you see that those categories directly correspond to the directives that were laid out for the task force. Appendix A as well also offers a crosswalk of initial recommendations made by the Senior Care Task Force and how they were approached by the working groups. That's on page 88. Appendix C lists the topics by tier, and that's on page 96. And Appendix D lists other recommendations which were discussed by the task force, and they considered them to be important enough to mention, but not as high priority to recommend as a formal recommendation. The report overall includes 15 Tier 1 recommendations, 24 Tier 2 recommendations, and 9 Tier 3 recommendations. After review and revisions to the working group's report, the task force agreed to present the Tier 1 recommendations, or those of the highest priority, from the report as recommendations of the committee. And these are located on the first page after the cover page of the report. They are in a gray box. So I'm going to go over those. The state should create a statewide conference or reinstate the Governor's Conference on Aging to create networking opportunities and share information. KDADs, providers, the Promoting Excellent Alternatives in Kansas, or PEAK program, and managed care organizations should support provider training and frameworks for person-centered planning, especially those for those with dementia. KDADs, provider organizations, and the legislature should create a rural healthcare coalition for aging services. KDHE and the legislature should better ensure psychiatric prescribers are accessible for consultation to complete medication evaluations for seniors receiving health service in all settings, using telemedicine when applicable and available, and ensure billing codes can cover a range of psychiatric services such as medication management, consultation, care coordination, and telemedicine. KDADs, DCF, KBI, and the legislature should establish a workforce clearinghouse, including direct care worker registries, and a position to coordinate among DCF, KDADs, and the KBI to increase accessibility and enhance safeguards and oversight of guardians, conservators, and caregivers that the facilities and individuals can refer to as a resource when questions about appropriate hiring arise. The state should add non-nursing professionals to the survey teams for adult care homes and consider models of mixed professionals for regional teams. KDAD should reactivate the State Aging Advisory Council, which includes representatives of supportive services and provider organizations. And the task force recommends the council mirror the composition of the Federal Area Agencies on Aging Advisory Council defined in the Older Americans Act. KDAD should establish a permanent full-time dementia and Alzheimer's disease coordinator position within its organization. The legislature and the Kansas Housing Resources Corporation should encourage collaboration to invest in housing options to increase the availability of accessible, affordable housing options for older adults. The state of Kansas should promote increasing access to the Program of All-Inclusive Care for the Elderly, or the PACE program, in underserved areas of Kansas to serve as a hub to administer social models of adult day services that focus on person-centered care for the needs of older adults and increase eligibility criteria for the program area. The state should expand the reach of the current PACE program and other providers to transport services and workers to those being served in-home across the state. The state of Kansas, with the Kansas Association of Area Agencies on Aging and Disabilities, should expand flexibility to incentivize providers via raising reimbursement rates to use the Senior Care Act program for services that promote choice, increase independence, and assist with overcoming unique challenges in rural, frontier, and urban areas. The legislature and KDAD should increase the caps for one-time only services with an annual review that ties the rate to the Consumer Price Index and create an exemption process to allow adequate funding for such items such as durable medical equipment and technology to address social isolation and home modification. KDADs in the legislature should seek funding and develop partnerships for the development and distribution of a new publicly available Kansas Elder Count book, similar to the ones that have been produced in the past. The state should provide appropriations to increase rates of service providers, to increase worker pay, support safe staffing standards, and ensure a stable workforce, minimizing wait lists. And finally, the legislature should provide ongoing government incentives with additional funding to increase the number of healthcare worker faculty and trainers. The task force sunsets officially on June 30th, 2023, but this report does represent their final work. I also wanted to mention, just because there are a lot of recommendations here, some of the relevant bills that correspond to recommendations in the report. So HB 2250 and HB 2345 both deal with the Supported Decision-Making Agreements Act, and that is recommendation 3.6 in the working group's report. And then House Bill 2243 and Senate Bill 62 deal with protecting vulnerable adults from the financial exploitation, and that is recommendation 3.4. And then finally, Charlie's bill, which you've probably heard about, was discussed and included by the working groups initially in the report. The task force ultimately decided not to include that recommendation formally because the Judicial Council was working on a study and had not yet released their final report. So they felt that they didn't want to formally recommend that until they knew more about what the Judicial Council would find. And so that is included in Appendix D, which is the other recommendations. But the Judicial Council report has since been published, and we have a bill for that, which is requirements for involuntary discharge or transfer of a resident in an adult residential care facility and the right to appeal. House Bill 2246 is currently in House Judiciary, and they are having a hearing tomorrow on Thursday. And the mirror Senate Bill 191 was just introduced yesterday, so it has not been referred yet. So I'm happy to take any questions on this report.
First of all, well done.
Thank you.
Thank you so much. Committee, do we have questions for Leanne? Senator O'Shea, you served on that committee, and we appreciate your comments and questions.
Thank you. Yes, thank you, Madam Chair. First of all, it's my first task force of this manner, and there's so many meetings. So it's interesting that, then it provides this report that's very comprehensive. All the stakeholders have been brought to the table. And I think the concern is always that it will just sit on the shelf. And so when I look at it, something that concerns me is how do we know as a legislature which pieces of this are action items for us versus others. As you can see in there, there's a lot of, KDADS does this or the state of Kansas does that. And so I guess I would just encourage everyone to use this as a roadmap when you're talking to KDADS, when you're talking to different stakeholders, and point them to this. I do know one of the tasks was to create an Alzheimer's position specifically. I think there's a bill that's out there about that. And then I do think it was interesting, one person on the work group, the very first bullet point about Kansas creating a statewide conference on aging, that went away a couple years ago. There used to be a group, kind of like a senior care task force, they used to meet. A lot of those have gone away. So it was the first time that some of these different stakeholders had gotten together in a long time, and that you know, a lot of these issues might be covered if they were more often meeting and collaborating on these issues. So I think that's something for us to consider. A lot of it too has to do with appropriations, so something to consider as we look at our budget. Thank you.
Committee, other questions for Leanne? Senator Petty.
Thank you, Madam Chair. And it's good to know that Senator Shea was serving on that. I would ask the question, because there are things that are on this report, and since I haven't looked at all, I don't know, 90 pages, I'm going to assume that as the task force was meeting, that they also referred to things that have occurred, that investments that have occurred, like it's mentioning about PACE and expansion of PACE, and actually that has occurred. We've raised, last year, we raised the level of funding for PACE, of what a client could keep of their own money, and we have expanded the options for PACE. So would that be true? Was that looked at?
Yes, Madam Chair, thank you. Yes, that was considered. I believe that they discussed that and they felt that that was still a priority, that that was still a program that could continue to be expanded to help serve particularly rural areas and continue to serve seniors in the state, because it seems to be working well, I think. That was kind of the thought, was that it has been expanded and the continuation of that would be beneficial.
Other questions, committee? Thank you so much for giving us this report today. In committee, we are adjourned.